So now what is this muscle? You can see
Trapezius.
trapezius. Okay, very good. So trapezius has three, horizontal, upper, and the lower fibers. So I am removing the trapezius. Then what you can see? Then there are, the three muscles in the same muscle plane just under the trapezius. So this is your levator scapulae in the top. This is in the upper part of the scapula, above the spine of the scapula. This is the levator scapulae muscles. In the same muscle plane, this is your rhomboideus minor, and this is your rhomboideus major. So this is in the medial border of the scapula. So that means if you are holding the ultrasound probe, the first layer of muscle, how you will be able to see your trapezius, and below the trapezius, depending, you will not be able to identify, differentiate between these three by looking at the structures, but it will be looking all same. If you are holding the probe above the spine of the scapula, means here, if you are holding the probe at this level, that means you are looking, second layer muscle will be your levator scapula. If you are holding the probe here, that is rhomboideus minor at the level of the spine of the scapula, and below the level of the spine of the scapula, if you are holding the probe here, then that is your rhomboideus major. So these are the second layer muscle that we remove. So between the spinal accessory nerve, how will be searching? Spinal accessory nerve will be, spinal accessory nerve is difficult to see. So we have to understand that it lies between the trapezius and the levator scapulae muscle. So coming back for the spinal accessory, we have to go below the trapezius, above the levator scapulae muscles, and your probe position will be above the spine of the scapula. So now let me remove these second layer muscles. So this was your rhomboideus major, this is the rhomboideus minor. I'm hiding this also, and your levator scapulae, I'm hiding that also. Then what you are getting? This muscle is your serratus posterior superior. So that means here, in between the rhomboideus and serratus posterior superior muscle, we are having the dorsal scapular nerve, and it is accompanied by the artery, and that is very nicely visible. That means the first layer is your trapezius, next layer is your either levator scapulae or rhomboideus minor major, and in between you'll be searching the spinal accessory, and between the rhomboideus major minor and the your serratus posterior superior muscle, you'll be searching for the dorsal scapular. After that, there is a thoracolumbar fossa. This is a thoracolumbar fossa, and after that, there is your erector spinae group of muscles. So that is what is, if I am removing this is the thoracolumbar fossa. So if I am that erector spinae group of muscles. So for the erector spinae muscles, what you have to do? We have to search for the. It's very simple. We have to. I'm removing all the muscles. And so you have to put our needle over the tip of the transverse process. Another thing you remember, this is very important when I'll be showing you in the thoracic spine also. So you see, after this spinous process is superficial, then lamina is quite deep. And here is your multifidus muscle. You see, here it is quite deep. And after that, transverse process is like quite elevated. That means after this is a bone, then the bone will be very deep. That means when you are sliding the probe from the midline to the lateral area, just little bit lateral area, maybe around 1 thumb lateral at this area about the lamina, it is deep. And again, if you are going laterally, then you'll be getting this transverse process, which will be very superficial. And after that, you'll be getting a small break, and then the rib will be started. So this is how we'll be seeing. And here in between the two rib, we'll be getting the little bit deeper, the pleura, very glistening, shining appearance. And here, the other important thing is your internal intercostal membrane and the costotransverse ligament. One costotransverse ligament is here, that is your lateral costotransverse ligament between the transverse process and the rib. And another costotransverse ligament is here, where it is from one rib from here to the above transverse process. That means it is little bit oblique. So if you wish to go for the paravertebral block, you have to puncture this. This is your superior costotransverse ligament. This was your lateral costotransverse ligament. You have to pierce the superior costotransverse ligament, which is continuous with the internal intercostal membrane. So you have to go between the costotransverse ligament and the pleura. Or if you are coming laterally in this way, you have to pierce the internal intercostal membrane and the space between the intercostal membrane and the pleura, that is for the paravertebral block. So I'll be trying to show you this in the thoracic spine.
Sir, I have a question.
Yes, yes, yes.
Sir, in chronic pain condition, what are the indication where we can go for erector spinae block?
Chronic pain
we do erector
conditions.
spinae block for acute pain condition, post-operative
Yes, yes,
cases.
that is true.
But for chronic pain,
yes, I'll be telling you what are the indications. So most
Yes,
of the time, as I told you, that if there is a myofascial pain, if you are getting the trigger points, it's fine. You go to the trigger point. You try to go below the in between the muscle plane as well. But in some
Yes, sir.
situations, when the area is very wide, not one
Yes, sir.
trigger points, you will be getting this kind of conditions frequently. In that situation,
Yes,
you can go 2-3 areas level erector spinae block. I personally have done few cases and not
Okay,
for local
sir.
anesthetic. Give dextrose there, and it will give
Okay.
fantastic. So if you are
Okay,
giving
sir.
in the wider area of the pain, mid thoracic areas, you have excluded all other possibilities, and then one
Yes,
of the
sir.
very important option is to go for the erector spinae.
Okay, dextrose, sir, how much and concentration, sir?
So dextrose injection should be given as a 5% concentration, physiological
5%.
research.
Okay.
So
And
hypertonic
20,
dextrose
30
is
ml.
given for the prototherapy, but for the
Yes, sir.
all this muscle plane block, your injection around the nerve or nerve root, then you have to go for the 5% concentration.
Okay. How much volume, sir?
Again, this is one of the very beauty of this 5% dextrose. Here, the volume you can give a larger one. Because
Yes,
if you
sir.
are giving other injections, say for example, if you are giving steroid, if you are giving local anesthetic, you are having a restriction of the volume. But here,
Yes, sir.
what we are doing, what is the mechanism? Mechanism is basically when you are giving this 5% dextrose, it will be going within the muscle plane and the nerves which are running within the muscle plane. So what
Yes,
is the
sir.
mechanism of pain here? Because this causes the fine entrapment of the nerves, of the pressure on the nerve, and that causes
Yes,
the vascular supply, the vasonervorum, which is basically supplying the nerves. So they are getting compressed, and the vascular supply to the nerve is compromised, and that is the cause of the pain. So when we are giving the dextrose around this nerve within the muscle plane, that will be dissecting these nerves out between the two plane and increases the vascularity of the nerve, and that is the mechanism how it works. So if you are giving a larger volume, you'll be having the better therapeutic. So now if I cast larger volume means how much? 1 liter? Obviously not. Something around 5 to 10 cc is okay. For the trigger point injection, you normally give 1 to 2 cc injections of local anesthetic. But here we can go up to 10 cc. Sometimes I have given wider area. I have given 20 cc also.
So should we go for every plain injection
yes, if you are having the
not responding
dilemma
with trigger point injection?
Yes, that is what I'm telling you. Suppose you are getting trigger point injection. Normally, what I used to do,
Yes.
Classically, you go into the trigger point and fancy fit manner, you are going around and you give local anesthetic. But then those days are over. Now, what we do in that trigger area, we go within the muscle, we go into between the first and second layer muscle, then go into the second and third layer muscle, and you inject their dextrose. This is one option. Or other option is, as I told you, go for the erector spinae block and go at 2 or 3 levels and give large volume around 20 cc. So that will be dissecting out the dorsal rami branches which is coming out there, and that will be giving very good pain relief.
Only dextrose, sir.
Dextrose is the best one.
And sir, how many means how frequently, sir, we should give, and how many injection for better?
Again, that is the beauty for the dextrose, that you can repeat it, but repetition is not needed. For the local anesthetic, normally you need to repeat it every week or sometimes 2-3 times. But if you are giving dextrose, most of the time, my experience is so good that only one.
Okay, sir. I'll try next injection, sir.
Yes. So trigger point injection, forget about the local anesthetic, steroid injection. And steroid nowadays, it is contraindicated. Steroid nowadays, it is told that don't give steroid because steroid in the muscle or muscle layer causes the muscle fibrosis, and that increases the contractility of the muscle. So don't give any steroid in the trigger point myofascial pain. No steroid.
Okay, sir.
So this is the spine of the scapula, and levator scapulae is from here. After the trapezius, we are having the levator scapulae. So while you are holding the probe, you palpate the levator spine of the scapula, and if you are holding the probe here, then after the trapezius, next muscle will be your levator scapula. And after that, what will be there? After the levator scapula?
And rhomboid minor.
No.
Levator scapulae, then
Erector posterior. Serratus posterior.
Serratus posterior, very good.
serratus posterior.
If we are coming down a little bit at the level of the spine of the scapula, then
Okay.
after trapezius, which muscle will come? Just now I have shown
Rhomboidus
Minor.
rhomboidus minor, very good. And if I am coming little below the spine of the
Major.
scapula, then after
Major.
the trapezius, rhomboidus major, very good, excellent. And if you are removing all these three layers, next layer muscle is your serratus
Serratus
posterior.
posterior.
After that, we are having the thoracolumbar fossa. After that, we are having the erector spinae muscle. Is it clear to everybody? So
Yes.
when we be holding the probe, we'll be doing like that. So holding the probe, we'll be palpating here, we'll be holding the probe, and we'll be getting all those muscles. And next, what I told you, so we'll be holding the probe here over the in between the rib, and we can come medially or opposite. We can do. We can start from here in the midline. We'll be able to see the two spinous processes. We'll be able to see the supraspinous and in the spinous ligament. Then gradually, we'll be going just lateral to that. We'll be seeing the multifidus and other erector spinae muscles, and we'll be seeing the lamina very deep. And then we'll be holding the making the probe in the long axis laterally. We'll be able to see the transverse processes like this, and then transverse process in between the transverse process. We'll be seeing the superior costal transverse ligament that is coming from one rib below and above transverse process in an oblique manner. And one of the way of keeping the paravertebral block is out of plane approach, going here and puncturing that costal transverse ligament and going deeper to it above the probe. And then if you are holding the probe more laterally, then over the rib in this area. Now here, this is your more superficial and this is your flat. When you are coming over the rib is a little bit more, the more rounded. And in between that, we will be seeing the pleura is mostly and above the pleura, the intercostal muscles. And if you wish to go for the intercostal nerve block, we need to just inferior and a little bit of anterior of the lower border of the rib. So if you are going the rib, the lower border, there is a groove through which the neurovascular part runs. So that is our target. Okay. So let us now focus on the volunteer. Okay. So which probe shall I take?
Linear probe, sir.
Okay. Very good. So linear probe, and I am taking the high frequency probe. Linear probe. So there are two options. One is your hockey stick probe or very high frequency probe. Another high frequency probe is XHD probe. So we have the hockey stick probe in another machine, but still better than hockey stick probe is this probe. So this probe is basically the XHD probe. It gives very good clarity of the superficial structures. So I am palpating the spine of the scapula. So here is the spine of the scapula. That means if I am putting my probe here, my aspect marker is towards the left side. So if I am putting my probe here, my aspect marker is towards the left side. So this is your scapula. So I'm teaching it, and let us see how you can see here. So this is your scapula. What is this muscle? Let me see what you can say. I was holding the probe above the spine of the scapula, and this is the blade of the scapula. I was holding probe like this, and there is a
Levator
muscle.
scapulae.
No,
Levator scapulae.
no, that is not the right answer.
Superficial muscle is trapezius, and next to it is rhomboid minor.
No, it will be coming in this side, medial side. I am calling this is the lateral side. This is the this is the
Lateral side.
lateral
This
side.
is supraspinatus.
Supraspinatus.
Yes, supraspinatus. Very good. That was supraspinatus. So this was your blade of the scapula. Above the spine, I am holding the probe. So this muscle, thin layer of the muscle is your
Trapezius.
And when we are coming, this is the edge of the scapula. If you are on the medial side, this muscle is from the supraspinatus fossa. This is your supraspinatus muscle. And here I was in the top, above part, upper part. So after that trapezius, what is this muscle? This muscle? Levator scapulae. Very good. And what is this muscle?
Minor.
No.
Serratus posterior.
Serratus.
Oh, serratus posterior. Sorry, sir.
Okay, I'm sorry.
Chip
You see, this was your. I am holding. This was spine of the scapula. My probe position is the upper part of the scapula, above the spine of the scapula. So if I am going here, anesthesiologist must be familiar with this picture. You see what is there? There is a suprascapular. Yes.
Suprascapular.
In this area, we are going to suprascapular ears nerve block. So this is your trapezius. After the trapezius, this is your supraspinatus muscle. So now here, I am going, this was the edge of the scapula. This was the edge of the scapula. I am going medial to that. And if I am going medial to that, so this muscle is your trapezius. After that,
trapezius, levator
scapulae. After that, this skin muscle is your
posterior, serratus posterior.
Serratus, and that then the paraspinal muscles are coming. So if I'm trying to do the, the spinal axillary nerve block, then my needle should be coming here, below the trapezius, in this layer. As I told you, individual nerve and the vessel is very difficult to see. Sometimes it is seen, sometimes it is not seen. I'll be searching if I can show you. And here in this layer, I'll be able to see the dorsal scapular. Now let me carefully search it. If I can show you. Okay, I can see these pulses when here. If you look at this, that is a dorsal scapula. I have come little down, and between the second and third layer muscles, some pulsations are seen. Can I appreciate that pulsation? Just below my, in this area, that is your dorsal scapular artery, and in that layer, you have to go for the dorsal scapula. Here also very fine pulsation is seen here. So that layer that accompanies nerve is you cannot see. But finally, what you have to do is you have to give injections, high percentage dose injection in this layer and in this layer.
So again, volume will be 5 to 10 ml or more.
Yes, 5 to 10 ml. But if you wish to give 20 ml, you can give that.
Okay.
I have many times I have given larger volume that is better.
So
Okay,
can we do all together on same sitting? Means.
Yes, normally we do like that only. We put the needle. And we go between the first and second layer, and then go to the second and third layer, and then you complete.
So we'll give either these two plain block or erector spinae block, or 3 of them all together.
You can do all 3 together also.
Okay. Thank you, sir.
So I'm holding the probe in the midline. So you can see here these are the two spinal processes. And in between, this is your supraspinal ligament. And this hypoechoic area in between the two spinal processes is the interspinal ligament. So now, if I'm going at this position, from this position, if I'm going laterally, what is happening? So now that you see the ultrasound beam is going deep. And now this is your lamina. This is your lamina. In between the two lamina, the gap is there. That is your interlaminar space. So just I was here initially. I can see the spinous process. And now I'm just gradually going, and I can see so deep it is going. And now I can see the lamina. These are the lamina. And now from here, I'm going still, this was lamina, I'm going still lateral. Now see what is happening. See what I was telling? Bone will be gradually elevated. Elevated. Now what is appearing?
Tip of
This
the
is your
transverse process.
transverse process. Very good. And you see the pleura is moving here. And
Yes, sir.
this is your costotransverse ligament. Superior costotransverse ligament, oblique. This is your superior costotransverse ligament. From
Yes,
one
sir.
rib we cannot see here because it is under the and this is your, so this will be obliquely oriented. So if you wish to do the paravertebral block, this is one of the options. By the out of plane, you can come here. Here's the your superior costotransverse ligament, and above the pleura, you can inject your drug here. But again, it is a little bit dangerous because you cannot see the nerve nicely. You cannot see the space very nicely, and not really nicely. So now at this position, I am going more laterally. Now see what is happening. Transverse process is vanishing. Transverse process is more superficial than the rib. Now transverse process vanished. And now the gradually ribs are coming. So these are the ribs. Here are the ribs. So now the pleura here is very glistening.
Yes, sir.
And these are the intercostal muscles. So this is if you wish to go for the intercostal nerve block, your needle should be coming like this, and just inferior border, you will be injecting your drugs. So this is your long axis scanning. And you see with the respiration, the pleura is moving, glistening pleura. So now if I am coming again from the lateral, I am starting. Over the pleura, I am putting my probe, and then I will be gradually coming medial. And you see what is happening. So here I was over the rib, very nice glistening pleura. I'm coming medially, following the ribs, and suddenly ribs will be changed. Now I cannot see anything here, and now suddenly the transverse process is appearing. So this was your rib, and this is your transverse process. Transverse process is more superficial. And here I can see the costotransverse ligament also. This is the costotransverse ligament from one rib to the transverse process. And I can see here the pleura. So this is where you can get this is the obliquely. So this is now very nicely seen the costotransverse ligament. And you have to puncture that to give the paravertebral block. Now I'm going more medially. Now you can see the lamina there. So there the lamina. In between this lamina, interlamina space, and the USG beam is going down into the spinal canal. I'm going still more medially. Now I'm coming over the spinous process. So these are the spinous process, and you can see the supraspinous and the interspinous ligament. Okay, so this is your longitudinal scan. Now I'll be in the short axis. So now here, this is your over the spinous tip of the spinous process. This is your spinous process. Why? Because I can't see below. This is a lamina, and this is your transverse process. Okay. So now I'm coming laterally. So this is your rib. This was not your rib. This was your pleura. Because very nice glistening structure, that was your pleura. Okay. But when I'm coming here, this is your rib. Okay, nothing is seen. And this ligament is your lateral costotransverse ligament. So now there is another approach for the paravertebral block is, if I can come here, where I'm seeing the very nice glistening structures. So this is your pleura. Above that, internal intercostal membrane, this white glistening line. So you can come in plane, you can pierce it, and you can inject it. Below the transverse process, you have to find out this membrane, the internal intercostal membrane, and the pleura. In between this black area, you can give another approach for the paravertebral injection. And here is your rib, and at that rib, this is your lateral costotransverse ligament. This is your transverse process, this is your rib, so this is your costotransverse. Okay, so up to this thoracic spine. Okay, no, another thing I forgot to mention the erector spine. Okay. Erector spine block is very simple. So, okay, somebody is asking question, but let me just finish it. Then I'll be again. If you wish to see any structures, again I'll be showing you. So this was what I was saying, spinous process. and then I'm going laterally. So now this was the lamina. And now I'm going, this was your lamina. And then I'm going more laterally and the transverse process is same. So at this point, you will be coming here over your needle will be resting over the transverse process, tip of the transverse process. So inject there,
Yes, sir.
that is your erector spinal cord.